Hiya and welcome to another episode of Neonates in a Nutshell. It's Emily here today and Amy.
Hello.
And we're going to be talking about neonatal abstinence syndrome, or NAS. So our objectives are to understand what NAS is, to be able to identify the babies who are at risk of this, to recognise signs and symptoms, and then to understand the care and the treatment of these babies. So first off, what is NAS? So NAS is a combination of behavioural and physiological signs and symptoms that occur in newborn babies as a result of the mother's dependency on drugs during pregnancy. So this can include both illegal drugs and legal drugs and kind of prescribed medication. This can then lead to drug withdrawal for the baby once they're born because they've been dependent on that medication while in utero. And the syndrome most often applies to opioid medicines. So what causes NAS? So almost every drug and medicine passes from the mother's bloodstream through the placenta to the unborn baby. And same as kind of food and things like that would pass through, medicine will go as well. This will include bad medication as well as good. So if the mother uses substances that affect her nervous system, these will also then affect the baby's. At birth, the baby may have become used to the drugs, so therefore when they are no longer within the in utero environment, this is when they may have symptoms of withdrawal. So then we're going to look at some of the drugs that may affect the baby. These are kind of the most common drugs that are most likely to cause symptoms of NAS. However, it's kind of just being aware that if mum was to use more than one drug, then often the symptoms are worse. So the frequently associated medications with NAS include opioids, so things such as heroin and codeine, stimulants such as cocaine, and then less frequently are things such as antidepressant medication, and then nicotine, marijuana, diazepam, and lorazepam.
Okay, so we're just going to have a little chat now about the sorts of symptoms that you might see. So because obviously the mum's been taking the drug and it's affected the baby, so every system can potentially be affected. So we just have to be aware when we're looking at these babies to make sure that we're looking at all the different symptoms. So the central nervous system, the gastro system, and also respiratory system are the common ones that we would look for. The symptoms that you're going to see really will depend on the type of drug that mum has used, and also when she last took it, how frequently she's been using it, for how long, that sort of thing. And then it's also really important to factor the baby into it as well. So if the baby is preterm or term, they will react potentially differently, and also it depends on their own metabolism as to how well or not well they will cope with the withdrawal process. So this sort of slide just really emphasises that. So in this table you can see that these are there's 5 different types of drug here, and you can see that there's quite a wide variation in the timescales that these babies can be affected. So methadone and heroin, as we said, are sort of the most common ones that we see, and they actually have quite a fast withdrawal time. So you might see symptoms within the first 1 to 2 days, whereas other things such as benzodiazepines can be up to 10 days. So that's really going to affect your management of these babies, how long they need to stay in hospital for, how long you're going to observe them, and things like that. So this slide just goes through the main symptoms that we are looking for with our NAS charts. There's obviously variation, but these are sort of the common ones that we would look for. So if we start at the top with neurosigns, you're looking at the babies can be really unsettled, so they can be very irritable with a high-pitched cry. We would look for any signs of abnormal movements, because that could be a sign of seizures. Often their sleep is disturbed, so because they're so irritable, they might not sleep very well, and so that's a bit of a vicious cycle. It can affect feeding and things like that. And then we would also look for sneezing and yawning. So they're not very specific symptoms, but in themselves you're sort of trying to gather a picture of how many of these are presenting. With regards to sucking, babies are very often, because they're unsettled, they have an excessive suck, and this can lead to feeding problems, because if they want to feed too much, you can then end up with vomiting or swallowing air, and then they can end up with gastro problems. These babies can get very hot and sweaty, which is quite unusual for babies, so it's something to look for. And the fact that they can get hot, they can be tachypneic, they can have tachycardia and an elevated blood pressure. So as you can imagine, they're going to be very unsettled. It's very unpleasant symptoms that they're having. Temperature control, we've already talked about that they can be hot. They can have quite excessive tone because they're unsettled, and we've already talked about potential seizures, but you can see sometimes they're sort of jittery, or you can see tremors. Finally, on this slide, we've already touched a bit on the fact that they can have feeding problems, and diarrhea can be quite a common symptom, and that can lead to its own problems, because if they're having excessive diarrhea, their weight gain can be difficult, and also they can end up with like sore skin, and then that makes them more unsettled. We've already talked a little bit about vomiting. So you can see this overall picture is just one of a very unhappy baby that's difficult to settle and difficult to sort of have a nice, calm control of their care.
So now we're just going to look at some of the management and how you could care for these babies. So first off, not all of these babies will be born at term. So some may present with other neonatal problems as well. So you may get a baby who's had a poor delivery and has maybe had meconium aspiration or something, and they would have NAS on top of this. So it's trying to determine what signs and symptoms are associated with what illness, and just kind of bearing it in mind that they may have NAS as well. So if they're particularly unsettled or they've got tachypnea, it could be related to both illnesses, and just bearing both of them in mind. And then also, even if the baby then became better in terms of their neonatal problem, they may have the NAS, which would be ongoing. So our aim is to try and keep these babies with the mum as much as possible. So this is to obviously encourage bonding. This might not always be possible due to medical or social reasons. So if the baby is particularly bad and really withdrawing, then they may need to be admitted to the neonatal unit. However, we would usually try and keep them together on the postnatal ward or on transitional care. So one of the things that you can do if you are looking after one of these babies is to review the mum's notes and then document any plans from the mum's notes into the baby's notes. And this just gives you a nice kind of thorough plan of action. Also, when the baby is born, it's not you can inform the paediatrician. However, it's not always necessary for the paediatrician to be at the delivery unless there were other concerns. So how is NAS diagnosed? So we've kind of spoken a little bit about the history of the mum. So you can find this out from mum's notes. So history of the mother's drug taking, which she might tell you verbally, or it might be in her notes. And it's just working through these, then being aware of what may affect the baby if she's on several medications. Another way that we can diagnose is through NAS scoring, which we will talk about a little bit more in a minute. And this just identifies if the baby has signs and symptoms and how severe and whether they require any treatment. We also can take urine samples for toxicology from the mum and the baby. However, the mum would need to consent for these. And then just being aware that we can also take blood samples and hair samples. This is usually within mum that it's taken. However, it's just being aware that this could be an option. It's not so common in babies. We usually would try and take a urine sample, but just being aware of some of the diagnosis.
Okay, so as we mentioned before, it's really important to have very thorough documentation with these babies. So when you are putting things in the baby's notes, it's just really useful if we've got details to do with mum's drug use. So I've already touched on some of this earlier, but making sure that you've got the name of the drug, the dose, when she's last taking it, and how long she's been taking it for. Especially if mum is an IV drug user, it can be really useful to sort of relate that to the serology results, because these mums are at higher risk of things like hepatitis B and C and HIV. So yeah, that needs to be documented. And then perhaps the most importantly of all is just to gather as much social evidence as possible. So if mum has any contact with social services, it's just good to document exactly what that is and the contact details, so her named social worker. With previous children, there might be care plans in place, so just sort of as much evidence as you can, and it just makes it that little bit easier. So once the baby's born, there's already like a nice plan in place, and everyone knows you know, where we're going next.
So now we're just going to look a little bit about NAS scoring. So this is a way of kind of looking at the baby's signs and symptoms. Some of the symptoms that we looked at previously on the slide of the baby. And this is just determining whether whether there's whether they've got any signs and symptoms and how severe these are. So below is a link to the local unit. Obviously, each neonatal unit will have their own NAS scoring chart. These do differ slightly between units. However, usually they do have similar signs and symptoms across the board. So some of the main principles of our local NAS scoring chart is the baby will be assessed and scored half an hour to an hour post-feed. If symptoms are present, and then you score 2. So say the baby was irritable, then they would score 2. If that's not there at all, then you'd score 0. You don't ever score 1. So it's basically 0 or 2. If you feel that the baby's a little bit jittery, then you would score 2, because it's kind of just one or the other. You repeat the observations every 4 hours if the baby's scoring less than 6. And then you repeat every 2 hours if the baby then starts scoring more than 6. And this is just because obviously this is showing that the baby is really starting to show signs of withdrawing, and you want to keep a closer eye on them. And then inform the doctor if there's 2 consecutive scores of 8 or more. And this is because then the baby may need to be reviewed, and we may need to start considering whether to give this baby oromorph, so oral morphine. So one of the important things is that this isn't just a kind of a snapshot of scoring. You want to see this baby throughout those 4 hours. So even if you were then to just document, say at 4 p.m, you would have wanted to see that baby a couple of times between midday and 4 p.m, just to kind of monitor how they were throughout that time. So you're going to score if the baby's been, say, vomiting or things like this. Even if it was at the start of the time, it would then still be included within their NAS scoring for that 4-hour period.
Yeah, so I guess that's the thing, isn't it? Sort of like in that 4 hours, which things have happened. So you're kind of, you're trying to build up a picture, aren't you, of where they're at the moment, because what we will see is if babies are withdrawing and we can't keep them settled, then that will just gradually increase, won't it? So I think it's that thing that, say for vomiting, they don't have to be vomiting at that point in time when you're doing the score. So it's just sort of getting an overview of the last 2 or 4 hours.
Obviously, we may try and keep these babies and mums together in a side room. So it's just being aware that although they're on 4-hourly NAS scoring obs, you will need to see them a couple of times during that time period. These babies do need to be observed, even if it's just kind of seeing how they are. Although you can ask parents how they have been, sometimes they may not give you the best picture, or, you know, if they're particularly scared and they, you know, they might hide things. So it's just making sure that you have visibly gone and seen this baby and observed them. So on this little chart, this is just some of the signs and symptoms to score. So this is on our local neonatal unit and the ones that we score. So whether the baby's hypertonic, high-pitched cry, whether they're jittery, so either when they're disturbed or when they're at rest, poor sleep-wake pattern, seizures, pyrexia, so a high temperature, respiratory symptoms, so tachypnea, things like that, poor feeding, vomiting, and loose stools. So some of the treatment here is that we could use for some of these babies, and it's just bearing these in mind. So you don't always want to medicate these babies. Some never kind of need to go down the oral morphine route. You could perhaps just kind of get away with just some of the other treatment and developmental care things, such as swaddling with a cotton sheet. So cotton sheet just to prevent overheating. Consider nursing in a side room to limit the noise of the baby, for the baby. Reducing light exposure and handling of the baby. And these babies, they do like to kind of be held quite a bit, and it's trying to work with mum, because obviously she will need rest as well. So trying to help her see that perhaps you can swaddle, put the baby in the cot, and give mum a little bit of a rest as well. Non-nutritive sucking, small amount of sucrose you could use, comforting the baby, and then depending on how severe the symptoms are, and this is where the NAS scoring kind of comes into play, if the baby's presenting with quite severe symptoms, they may require oral morphine. And the oral morphine would be once the doctors have reviewed the baby and decided that this is the treatment option that they would like, and then it would depend on what they decide, and the baby would usually be given that maybe 4 hourly to start with, and then this would be reduced over a couple of days in the hope that you would wean this and the baby would come off of the oral morphine fairly quickly or in the amount of time that they required. Okay, so that was just a little run through of NAS. Hopefully kind of just gave you a few ideas of how to treat these babies. Main thing is not to be afraid. The support is there if you need anything. If you're worried or you feel like you haven't scored the baby correctly, then just ask for support in this.
Yeah, I think it's one of those things that it can be quite subjective, can't it? So often when we're seeing these babies, we do just sort of check with each other, you know, especially some of the more sort of less specific signs. It's sort of, you know, do you feel that they're jittery or just a bit unsettled and things? So yeah, it's good to work as a team, isn't it, with this?
Yeah, so again, as usual, if you've got any questions, then come and talk to us on the unit. Otherwise, yeah, just see how you go with scoring babies, and just make sure that you're documenting, speaking to people for support when needed, and things like that.
Okay.
I think that's it. Okay, thank you very much for listening. We will see you next week.
Bye.